Hey everyone, it's Adam Farkas. Welcome to another ODwire webinar. Thanks so much for making it out tonight. And tonight is all about building your practice with Optovue iWellness and Angiowellness with the Solix by Visionix. Before we get started, I just want to remind everyone about some ground rules for the evening. So on the right side of the screen, you'll see a little questions box there. Feel free to type into that box and ask questions as the show unfolds. I will hold them aside and then verbally have a little Q&A with the speaker at the very end. And with that said, let's talk a little bit about the Solix. So the Solix Ultra High Speed Full Range OCT, we have seen this great new instrument several times before in webinars that we've done this year. You've seen us talk about the instrument in general with Dr. Rodman, who's here back with us again tonight. She did a great overview of the instrument. We've seen Dr. Nate Lighthizer talk to us about its use in different diseases. And tonight we're going to learn all about how it works with the iWellness and AngioWellness protocols that can help you find and monitor diseases and help you build your practice. So this is a little bit more in depth about the instrument because I know it's been a super hot topic and people want to learn so much. And again, very fortunately for us tonight, we have Dr. Julie Rodman back with us, and she's the chief of the Broward Eye Care Institute in Fort Lauderdale and a professor of optometry at Nova. Obviously an expert on OCT and OCT-A. She's even written the Optical Coherence Tomography Atlas, a case study approach, which is the first reference book on the topic written by an OD, and she is one of the premier optometric educators, and she makes very complicated topics seem very simple. So we are thrilled to have her back here tonight. So with all my blabbing, let me get this out of the way. And Julie, I'm going to give you control, and we can get going here.
Thank you, Adam, and thank you all for tuning in. Hopefully everybody is in a safe place and won't get hit by the hurricane that's coming in the next day or two. So that's kind of on all of our minds that live here in the Southeast, and I guess a little bit further up the coast as well. That being said, Adam eloquently stated that tonight we're going to really focus on Solix, iWellness, and AngioWellness. Okay, so I want to just spend the first couple of minutes here just giving you a general overview about the Solix. I've been extremely fortunate to have the Solix in our clinic at Nova for quite a while now, so I've become pretty comfortable with it, and I do have to say that it has been a blast to work with. It has some new and exciting features that previous models did not have, including innovations in this new iWellness and AngioWellness program, which we're going to focus later on in the presentation. So on this slide here, you can see specifically what the Solix is known for, and I'm going to kind of read these through pretty quickly. But the first one is that this instrument has what we call full range anterior segment. So essentially what that means is that you can take one scan and you can get an image from the anterior surface of the cornea all the way to the anterior surface of the lens. So you get a panoramic view, limbus to limbus, of the entire anterior chamber. And this is one of my favorite features because patients that perhaps have narrow angles, let's say, and you can't do gonioscopy on them for various reasons, this modality allows me to just take one picture and get a really good assessment of their angles. So this has been really one of my favorite things. I'm going to show you in just a minute what this picture looks like. The next innovation is what we call full range retina. So we always knew that Optovue's OCT was outstanding, but the Solix has taken those outstanding images and made them not only wider, but taller. So now we're getting more information in our scans. So if you think about a high myope, we know that high myopes are extremely difficult to image because of the concavity of the retina. With this new modality, we can actually get almost the entire macular area and peripapillary region in one scan, and we don't lose any of the definition, so the resolution is outstanding. For glaucoma, there is a brand new platform. I'm going to be honest, it took me a little while to learn it, but I love it now. It's going to give us earlier detection of disease, and we'll talk about that in more detail in just a minute. This is fantastic, this next thing. This thing has a camera. Not only does it has a camera for optic nerve and retina, it also has a camera for anterior segment and external fundus, external photography. So if you have a patient that's maybe a little bit more challenging to move from instrument to instrument, this machine will allow you to do everything kind of in a one-stop shop. This has been phenomenal. Angioanalytics, so we know and love Optovue for their angio. There is nobody, in my opinion, that makes a better angio model than Optovue. Now with the Solix, we have wider scans. So we know that one of the limiting factors that we used to have with OCT-A is that the scans were, small. We couldn't really visualize past the equator. With this new technology, we can not only montage images together, but in a single scan, we can get a 12 by 12 cut, which is amazing. And then the last one here is what we're going to focus on a bit later, is the Angiowellness and iWellness platforms. So this is a beautiful picture, beautiful pictures of what I just described. On the top left, that is that full range anterior chamber, anterior segment image there. You can see that it goes limbus to limbus. You can see here, I'll just use my arrow, cornea, anterior feature of the cornea all the way down to the lens. And this is what I was talking about with the angle. You can just brilliantly see here how close the ciliary body band is to the posterior section of the cornea, and make a really nice angle assessment just by looking at the photo. On the bottom here, we have our pachymetry and epithelial thickness map images. They're 10 millimeters. On the right, you can see that external photography that I was talking about. And look at the meibomian gland testing. So you can look at the meibomian glands and actually check for any atrophy. So this is the first company, first machine that has a combined OCT feature with this, what we call meibomian gland evaluation. And then on the right-hand side, you can just see some more really, really fantastic external images of a really pretty iris there that I don't see very often in my clinic. Okay, whoops, sorry. I'm having trouble here, Adam, seeing the arrow. Let me see if I can use this. My apologies. Okay, this is what a printout of the full retinal report is going to look at. So what I'd like to do is just kind of walk you through what this is and show you how much is really incorporated into this scan. So on the top right and the top left, you're going to see your fundus photo. So again, this is incorporated into the technology, and it's going to come out onto the printout. So if the patient has something pathological on their fundus image, not only can you look at it kind of side by side, both eyes, but you can look at it in tandem with not only the OCT-A, but also with the B scans and other information, which I'm going to explain right here. So directly underneath the fundus photos, you can see our B scan image that correlates with whatever the line scan is that you took. Underneath that, you can see your GCC thickness map that's given on a micron scale, and your retinal thickness map, which is compared to a brand new reference database that the Solix is kind of highlighting, and we'll talk about that in just a minute. In the middle of the printout are our angio findings. So you can see the 4 different plexi: superficial, deep, outer retina, choriocapillaris. If you're a person that likes to look at metrics or quantitative data, on the bottom of the printout, you can see the angio information, superficial vessel density, deep vessel density, with all the different kind of quadrants there on a quantitative metric scale. On the right, you can see the foveolae vascular zone metrics. And then your retinal thickness map is also given there compared to the reference database. And you can see that on the right-hand side of the printout, there are many different radial buttons that you can press on here to really change however you want to visualize. If you like to look at angio on a vessel density map, you can click vessel density up here, and it'll show you these on a color-based scale. You can also press FAZ, and it'll highlight the foveolae vascular zone for you. So what's really beautiful about this is that it's, again, a one-stop shop. Everything is on one printout. This is what the new disc report looks like. And there's a lot on here. And again, when you first start learning this, it might seem a little bit overwhelming, but I will tell you, and I'm going to walk you through it right now, it's actually very organized and very easy to interpret. So on the top right and the top left, you'll see the optic nerve head scan. So you'll take an optic nerve head photo, and the machine will crop this so that it can kind of be fit onto this printout and set next to all the other data. Right next to the optic nerve head photo is our reference database map that shows you where in your kind of T-SNP, your temporal, superior, inferior nasal, where does it fall outside of the reference database? And you can see the coloration there will highlight any areas that fall outside of that reference database. As you move down underneath the fundus or the optic nerve head photo, you can see the GCC thickness map, once again, pixel by pixel on a micron scale. You can see the RNFL thickness map also compared to the reference database. As you move down, you'll see the angio map. This happens to be clicked on vessel density. If you remember from previous webinars, darker colors mean thinner. So you can see here that this patient, wherever there was thinning, you're going to see those navy areas. And then on the very bottom, there's our B scan, our peripapillary B scan that actually is movable, so you can move it to kind of look at different things. And on the bottom left is the new reference database that we talked about in previous webinars, so I'm not going to go into a ton of detail, but basically it expands our statistical values for certain people. So if there was a person that perhaps we weren't sure, was it red, was it yellow? Now we have this orange area. So it kind of tells us, well, maybe we're not sure based on this particular test, but let's do more testing on this patient to determine where they fall in the normative or reference database. And in the middle of the printout, you can see your T-SNP map and all of the quantitative data that you're used to seeing, perhaps if you were using the Avanti. You will appreciate here that these hatched marks, the orange hatch marked lines, are referring to this new reference database. This shows you here the new glaucoma change analysis. So essentially on the top, that's going to be your RNFL change map. On the bottom is the GCC change map. You can also see the right eye and left eye superimposed upon each other, and you can also look at all of the different visits there. And what's really cool, this is a new feature, is now you can see 6 different quantitative maps. There's a superior, inferior, and so on and so forth. And it's showing you each visit just really compared, right eye compared to left, in a very easy to interpret fashion. You don't have to sit and look at trend lines and values and remember decimals. This just shows you it's easy. If the line is trending down, patient is falling outside of their, I should say that there is evidence of progression. And then on the right-hand side, again, are your quantitative numbers showing you visit to visit in different parts, different RNFL analysis and GCC analysis by quadrant. This highlights the beautiful capability of this machine to take an optic nerve head photo. You can actually even color in both the rim area and the cup area if you want a little more assessment or a little more data on that. And you can see a fundus image on the top right as well. There's a lot of different capabilities. You can see here, you can increase contrast, increase color, and really get a nice image that you can place, which will show up, I should say, on the report. You can appreciate even on this picture, this patient has some diabetic retinopathy, little dot and blot hemorrhage there, another one here. So I can't emphasize how useful this is when you're trying to look at an OCT-B scan alongside a fundus image and not have to take a patient back and forth between machines. This is highlighting beautifully a patient that has what we call foveal schisis, probably from high myopia, and this shows you that wide scan that we were talking about. So this is a 16 by 6.25 millimeter scan, and this is allowing us to get the whole entire retina, I would say whole entire retina, but a huge portion of the retina in one scan. You can also visualize with excellent resolution what's happening in the vitreous body. So what's important to emphasize here is oftentimes when on older machines, when you try to get such a big scan, we would lose resolution. This is 100% not the case here. I mean, this is really a brilliant image of a patient that has a lamellar partial thickness macular hole, possibly due to myopia or has myopia as well. On the right-hand side, you can see an en-face cut showing a wedge defect, probably in a glaucomatous eye. So using that en-face capability really highlights, this peripapillary and paramacular region. And then on the bottom, you can see a retinal thickness map using our reference database, using different colors to highlight areas of abnormality. This shows us here, so on the new glaucoma algorithm, basically let's just start on this side. This radial scan is what we used to use. You can see that the areas in between each of these cuts is fairly large. And really the way to think about this is, what if a patient had a defect that was falling somewhere in here? Would we miss it because the scan was capturing such a large area? So now the new algorithm shows you how tiny the slices are between each section of the scan. And what this does for us is allows us to pick up abnormalities much quicker. because if you're scanning at these tiny microns, you're going to be able to pick up things much faster than if you're getting this big chunk in one scan. So if you look at these number graphs or these lines on the right, the old technology, it would take over 1.5 years because of that larger micron spacing to pick up a progressive change than with the new technology, where it only takes 3/4 of a year to pick up on the same change. So basically, I mean, this is a lot of scientific jargon that I'm not, really a professional at, but what I do know is that the new technology gives us better reproducibility and repeatability in our findings because we have better resolution with these finer micron cuts. All right, so I'm gonna kind of switch over gears. That's an overview of Solix. If you can't tell, I'm excited about it. I'm super excited about it. I think that the technology has certainly made me a better diagnostician, but I want to focus for the rest of the webinar on the wellness platform. Optovue has been known historically to be a leader in OCT technology, and one of the things that has put it where it is today is because of their wellness platform. Doctors around the world are using the wellness platform to essentially capture more patients by finding more disease. So they're using this, and I don't like to use the word screening, but it's essentially a screening test. It's allowing us to kind of take a picture of a patient and see if there is disease. So here is the summary of what we're going to go into. The Solix Wellness Protocol is a valuable assessment tool that can reveal the need for more extensive imaging and streamline our exam process by confirming normal or aiding in diagnosis of pathology. So one of my friends that I know, many of my friends at Optovue like to say, in order to diagnose disease, you have to find disease. And so sometimes taking scans on patients where you think maybe there isn't even pathology will identify things, again, that are there that maybe you weren't expecting to be there. So here's the critical question: are you ready to take a proactive approach to eye health care? And that is really what wellness is all about. So you're going to detect abnormalities before you even see the patient. And a lot of doctors are using this. They're doing fundus photography, they're doing a wellness exam, and then if they find something, they'll bring the patient back to do more specific tests. So even though I'm not here to talk about generating revenue, that's essentially what this machine does, or this, I should say, this algorithm does, because you find something and then you determine, well, now I need to do more advanced testing. And that's when you start scheduling the patient back for the more specific tests. So this is what the wellness report looks like. It's essentially a one-stop shop, a one-stop printout, where it's going to give you valuable information not only about the retina, but about the optic nerve head and GCC and RNFL, things like that. So on the top there, you can see there are 4 B scans, 2 horizontal, 2 vertical, which are scrollable. Okay, so you can move through those. So this is going to help you to eyeball maybe an anomaly that, gee, you didn't think was there. Underneath the B scans, you can see the retinal thickness maps, and hopefully you can appreciate, if you are an Optovue user, that these retinal thickness maps are bigger than they used to be. It's a 12:9 retinal thickness map. So if something didn't fall exactly in that area of the optic nerve or fovea, we might have missed it. Now we're getting a bigger retinal thickness map. Right beside the retinal thickness map, you can see the ETDRS grid, which gives a quantitative metric to the retinal thickness map, and it's based again on the reference database. So you'll see those p-values, the statistical significant values, are going to show up on there to compare the patient to the reference database. Underneath it are our GCC maps, and hopefully you can appreciate as well that the GCC maps are much bigger than they used to be. So it encompasses a bigger area. You can pick up more pathology. On the bottom of the scan, and this is an Angiowellness printout, you can see that there are angio scans. We have one that the orange arrow is pointing to the foveal avascular zone. You can just tap on it and it'll give you a metric, which you can see right over here. It measures it for you. It also gives you the perimeter value, which has been shown to be very important in diabetic patients. And then we have the superficial capillary plexus on a vessel density map with different metrics. And then in the center here, you can see that the GCC map, which are these, is broken down not only by quadrant, but it gives you an inter and intra-eye comparison. And we know that in glaucoma, we're looking for inter-eye and intra-eye comparisons to determine if there is pathology. So basically what this scan is doing for us is not only looking at B scans, right, identifying maybe retinal pathology that perhaps we didn't know was there. It's also giving us an assessment of the GCC. And the GCC is super important when we're trying to look for early glaucomatous damage. It's also useful in superficial retinal disease. And then we also have the Angio platform on the bottom, which we'll talk about at the very end here and show you how that can be incorporated into making excellent management decisions and clinical decisions. So what might you uncover by doing these wellness scans? These diseases, including AMD, diabetic retinopathy, glaucoma, vitreomacular interface disorders, and really so many more things. You'd be surprised how much you might pick up by doing this exam. So realizing that your healthy patient population may not be all that healthy. And I put this in here because when I speak to doctors about the wellness exam, they say to me, well, I work in Costco, or I work in LensCrafters, or I work in a private practice where I'm doing mostly contact lenses. I don't see disease. And what I would say to them is that you may not think you're seeing disease, but I guarantee you by running the wellness scan, you're going to find something that you did not know was there. I think that a lot of times we get into a comfort zone and think we're not managing disease. Everybody has disease, and that's what this technology is good at finding for us. So what I want to do is go through a couple of cases and really show you how this technology can fit into a practice. So this is a 57-year-old Caucasian female who comes in for a routine eye exam. She's 20/25 in the right, 20/20 in the left. She's relatively young, 57, and she's got mild vision reduction. I will add that there's no lenticular changes or corneal opacities that would lend to a 20/25 visual acuity in that right eye. So the first thing we do before we even look at the patient, which is kind of where I feel like this wellness scan really shines, is we get a wellness scan, okay? And this is the right eye. This is the eye that has the decreased vision. And what you'll notice on the B scans on the top is that the patient has an epiretinal membrane. So the epiretinal membrane is likely the reason that the patient is 20/25. You can see that there is a retinal thickness map on the bottom left. You can see the ETDRS map in the middle that's showing you with the new reference database where this patient falls. You'll notice that those lines are on the bluish side, which means that this patient probably has a little bit of a thinner retina than the reference database. And on the right-hand side is that GCC map. Remember that the GCC map is going to be abnormal in patients that have abnormalities at the vitreoretinal interface because the ganglion cell complex sits very superficial on the retina. And then on the bottom, you can see the different metrics that are showing you what correlates with different parts of the GCC. So there's a lot of information here. You may or may not decide to bring this patient back for other scans, but if you did, you certainly could. I mean, this is the fundus image that was taken with the Solix. You can see that there's a little bit of graininess or grittiness to that macular area, but what's kind of cool is that if you looked at this, it's not that obvious that there's a problem. And that's really what I want to highlight here is that if you looked at this patient clinically and this is what you saw, would you even do anything? Would you even, perhaps they have a glaucomatous nerve, but would you even do anything for the macula? And so having that wellness scan shows us that yes, this patient actually had an abnormality. And if you chose to, you could bring them back and do more testing, which is what this is. I don't know that it's necessarily necessary in this case. I think we kind of got what we needed on the wellness scan, but this just shows a quick view report of using the analytics platform with vessel density and all that other stuff. Again, probably not 100% necessary in this patient. The second case study is a 78-year-old Hispanic female who comes in for routine eye exam. She's asymptomatic. She's 20/25 in both eyes. She's got NS bilaterally that's consistent with her mild decrease in vision. So we're not expecting to find any pathology, right? We're happy that we can explain the vision by the lenticular changes. But if you're running the wellness scan as part of your quote pre-exam testing, This is what we found. And who would have thought, right? So looking at these pictures here, you can see that this patient has, this is the right eye. You can see that the patient has a lesion sitting underneath the retinal pigment epithelium, a hyperreflective lesion. And then there's some fluid that's also kind of hanging out in that area. Shocker, right? Who would have thought? She's 20/25, which is pretty incredible. But this is what the OCT-B scans are showing us. And I'll show you her fundus image in just a minute, but you can see the retinal thickness map and the abnormalities that are consistent with that B scan. You can see the ETDRS map, the GCC map, but in this particular case, those B scans are worth $1 million. So if you're wondering what that is, this is what the patient's fundus looks like. If you look at the left eye, pretty unremarkable. The right eye has an anomalous lesion right over here. So what if you were doing an exam on this patient and maybe you saw this greenish grayish area and you weren't really sure what you were dealing with? Well, certainly the wellness scan identified something. Hopefully, if you're really good at interpreting OCT, you identified that, I'll rewind here, that this was a choroidal neovascular membrane. And let's say you weren't sure what it was. So this is the kind of patient that I certainly 100% would bring back for more testing. Again, generating revenue, but not only generating revenue, taking the best care of our patient. So here we can see, if it loads, here we go. This is a quick view report of this patient. And you can certainly see beautifully on the angio report on top that this patient has a net, has a membrane visible in the outer retina, visible in the choriocapillaris. So if you're not very good at OCT interpretation, maybe you identified that there was an abnormality on the OCT-B scans, but you weren't sure exactly what you were seeing. Once you get this angio report, it becomes fairly obvious that this patient has a choroidal neovascular membrane. And I wanted to just highlight another capability of the Solix. You can use a color-coded picture to show the depth of a lesion. This is a montage where we put together the optic nerve head scan and the retinal scan. And you can see in yellow here that this is a very deep choroidal neovascular membrane correlating down here with the outer retinal space. So as you can see here, there's so many functions of this technology. You know, if you weren't sure where this membrane was located, this montage or this ability to use the color-coded metrics certainly help. Let's move on to case 3. 40-year-old African-American male comes in for routine exam. He does tell me that his left eye feels, quote, off. He's 20/20 in his right, 20/25 in his left. Anterior seg is unremarkable, and he's 40, so he's got a little bit of decreased vision in that left eye. So we get we get a wellness scan, and you can see here that this patient, hopefully you can appreciate that this is a neurosensory detachment or central serous choroidal retinopathy. So again, who would have thought? Retinal thickness map is, you can see red there, which means increased micron thickness correlating with that fluid. You can see how the ETDRS map, the numbers are kind of in this orange diagonal, which means we're thicker than normal or the reference database. And the metrics, the GCC is not affected because this is in the deeper part of the retina. Looking at a fundus image sometimes, or even just looking clinically, we all know sometimes it's very easy to see subtle elevation. So maybe you were looking at this patient and you could not appreciate why the patient was 20/25, but the OCT, the wellness scan, highlighted the abnormality for us. And perhaps you decide that you want to bring the patient back to do further testing to confirm that there is no neovascular membrane associated with this CSR. We know that patients that have CSR, or I should say chronic CSR, do run the risk of developing choroidal neovascular membrane. And I always recommend getting angiography on these patients. So this is another patient that we pick up the abnormality, we educate the patient on the abnormality, and then we have the patient come back for further testing. Let's look at the next one. 80-year-old Hispanic female, history of dry AMD. She's 20/30 in the right, 20/25 in the left. She's got a little bit of NS, consistent with her mild decrease in vision. So we're not really looking for very much, right? We know that she's got some dry AMD. And here's her wellness scan. You can appreciate that she has drusen deposition. This is her right eye. You can see on this cut here, the little drusen here. And remember that we always want to look at more than one OCT scan, right? OCT is a dynamic test. We want to move through scans. And why I emphasize that here is that AMD is graded based on the size of the drusen and presence or absence of pigmentary changes. So looking at this scan, you can see that this patient actually has fairly large, or at least I should say one large, drusenoid pigment epithelial detachment here. This puts this patient into the category of intermediate AMD. That being said, this is a patient that should have further testing. I always do angiography on my AMD patients to make sure there's no leakage. And you also want to make sure that there's no areas of atrophy or anything else that perhaps you couldn't pick up on the B-scan. The other tests, the other parts of this are, pretty unremarkable. She also has a little epiretinal membrane here, which is probably why the GCC is outside normal limits. So really what I'm trying to highlight here is the utility of this wellness scan to pick up so many different things. Maybe you weren't sure what that reflectivity was, then you look at the GCC and you can see that. This is a picture of that patient's eye. Really solidifies that these drusen or the drusenoid deposits are on the larger side. So if this patient was told, I have a little bit of dry AMD, it's early, we can certainly see based on the wellness scan and based on the fundus image or fundoscopy that this patient is certainly in the intermediate stage of AMD. And here is the OCT angiography of this patient, really confirming that there is no exudation. There's no evidence of neovascularization. So again, I always recommend doing this on any AMD patient to confirm or negate the presence of any choroidal neovascular membrane. These are bigger slabs, just showing you, this is the outer retinal slab. I'm sorry, this is the choriocapillaris slab, and you can see that by this red line down here. This is just a shadowing artifact or defect, probably from some drusen, which you can see on the en face image, but there's no evidence of any bleeding. We're getting there. I wanted to show the utility of the wellness scan. This is number 5. This is an 80-year-old Hispanic female who also has a history of dry AMD. She's been using her home Amsler grid and noticed a black spot in that right eye. She's 20/80 in the right, 20/30 in her left. And these are her scans. I mean, there is a lot of abnormality here. You can see that there is almost what looks like a macular hole here. I mean, it looks like she's got a loss of tissue from ILM down to RPE. And then she also has this, what looks like kind of an attenuation or thinning of the RPE with lots of hypertransmission. You can see on the retinal thickness map that there is this area here that looks very abnormal around the fovea. But what's kind of interesting is that when I look at this, I think to myself, it looks a little bit atrophic, but yet the colors here are helping me because the colors are showing me that there's actually tissue here. It would be blue if it was atrophic. Although here on the ETDRS map, the data definitely looks thinner. So there's a lot of stuff going on here. So maybe you're questioning, well, what the heck is this? Does this patient have geographic atrophy? Does this patient have a membrane? So this is a patient that we certainly identified that there's an abnormality on the wellness scan, and we would bring her back for more testing. This is what the fundus image looked like. So really, wow, right? So you can see here it's obvious that this patient has drusen, atrophy, bleeding, peripapillary changes, lots of stuff going on. And we bring the patient back, and you can beautifully visualize here what we called an old filamentary choroidal neovascular membrane. This is a patient that has had a membrane for a very long time. It's probably inactive at this point. However, I would still refer this patient to a retina specialist. But this is the super case really showing, if you were looking at, let me rewind this for a minute, if you were looking at this wellness scan, and it's confusing for me as well. What exactly am I seeing? What's the deal? Why is the fovea look so funny? Is there atrophy? Is there bleeding? This is a really nice example of using the advanced testing that this technology offers to pick up on this choroidal neovascular membrane. These are just the magnified image. This is the choriocapillaris. Just look at how beautiful it's illustrating this membrane. This is a montage image, again, nerve and macula together, and you can see the membrane living underneath here. I think this is the last one, and then we're going to just do one case on wellness, on the Angiowellness. So this is a 35-year-old Caucasian male who comes in for a routine exam. He's got no ocular history, and he's 20/20 in both eyes. And here's his scan. And for those of you that have heard me do OCT lectures, hopefully you can appreciate that this patient has what we call an ILM drape, which is pathognomonic for macular telangiectasia. There's also some outer retinal involvement. But let's say you didn't know. Let's say you saw this and you just weren't sure what was going on. Patient's not diabetic. Patient doesn't have any reason to have these intraretinal cystoid spaces. And we get AngioAnalytics, we get OCT-A, if I could talk. And we know that macular telangiectasia affects the superficial and deep plexus, usually the deep plexus first. And what you can appreciate are what these little anomalous vessels temporally here. They usually take on this kind of right-angled appearance, diving into the foveal space. So hopefully if you looked at these scans, you could appreciate that this patient has this anomalous vasculature temporally. And I think I have larger views. You can see here the foveally vascular zone is completely distorted, and you can see these anomalous vessels kind of diving into the macula there. And there's my deep plexus. So just think about how that original wellness scan found something that perhaps we would have totally missed. The patient was 20/20, was not having any visual abnormality, and yet there's a lot of pathology here going on. And this is just the montage. Hopefully I'm blowing you away with these images, if anything, because I think the resolution is just outstanding. All right, and then the last part, in the last couple minutes we have, that was all wellness. If you wanted to, you can incorporate Angiowellness. So we know that obviously the Solix has angio on it, and I've shown you a lot of angio, but on advanced testing. If you wanted to, you could actually incorporate angio into your wellness exam. So not only are you looking at structural abnormalities, you can incorporate functional abnormalities as well to give you advanced visualization. So this is what the Angiowellness report would look like. Everything is the same except for the bottom. Now we have, and I mentioned this right at the very beginning, we have a map of the foveally vascular zone. We have the superficial capillary plexus with metrics as well. So I try, if it's a good patient, to get it. It does take a little bit longer. Sometimes it's just more feasible to do it without the angio and bring the patient back for the advanced testing if you so wanted to, which is really what I was showing you on all of those other examples. But if you do incorporate it, let me show you what it would look like. So understand, first of all, what normal looks like. So when you look at angiography of what we call the radial peripapillary capillaries, that is the vasculature surrounding the optic nerve head. It's probably the most important scan to look at in glaucoma because we're looking at the vessels feeding the optic nerve. But I would also argue looking at the superficial vascular complex is also extremely important because of the GCC and the ability to pick up early changes. So you can see here essentially what normal would look like. I would say that this might be a little darker than what I would like to see, but it's hard to get perfect images. But this left eye shows what a normal superficial vascular complex should look like. So this is what normal looks like. So if you had a patient that had glaucoma, what would you see? So you can see here again what normal looks like. You want nice, bright colors. As glaucoma becomes more progressive, you can see how there's more navy showing up on these scans. Remember that navy or darkness means lack of perfusion. So let's look at an example here to kind of drive the point home. This is a 45-year-old African-American female. When you look at this patient's optic discs, they certainly look suspicious for glaucoma. The patient looks cupped. But something that I always think about, especially in my population, is megalopapillae, which means that they have large optic nerves, but they don't have glaucoma. And I think that oftentimes we misdiagnose these patients because, yeah, they're definitely cupped, but they've got so much rim tissue because the disc itself is large. So this is a really good time or a good utility of using something like the wellness scan to see, does this patient have glaucoma or do they just have megalopapillae? So here is the wellness scan on this patient. You can see, or I should call the AngioWellness scan. On the top, we have our 4B scans. We have our retinal thickness maps. We have our ETDRS maps, our RDB, our reference database, GCC maps. And on the bottom, we have our angio maps. Hopefully you can appreciate that these superficial vascular maps are pretty navy. And what's cool about this is that really nothing else looks too outside the normal limits. The GCC looks okay, but those vessel density maps are telling me something. In the absence of other disease, and this patient doesn't have other disease, so in the absence of other disease, what are those vessel maps telling me? Does this patient, and this patient's young, she's in her 40s. So what is this alluding to? So tons of literature will tell you that angio or OCT-A picks up abnormalities a lot of times before we see it structurally, before we see it on the GCC. So this is a patient that certainly looks like there's something affecting the vasculature. This is normal. So if you look at these side by side, the control is on the left side of the screen and our patient is on the right side of the screen. Hopefully you can appreciate here that there is definitely a decrease in the vessel density of that superficial vascular complex in our patient. This picked up something before any other part of that printout. So this is a nice example of, in our glaucoma patients, should we be running AngioWellness and not just wellness? 100%, because these vessel density maps may actually pick up information before the GCC or any of the other findings. So this particular patient probably does have glaucoma. And this is that printout that I was talking about before, where you can get your disc photos, you can get it on the RDB compared to the reference database, you can look at the RNFL map, you can look at the vessel density. And remember, there's 1, 2, 3 different ways of assessing the optic nerve head so that you have tons of information. You can look at it, again, compared to the reference database. You can look at the RNFL thickness, and you can use the angio. And using the more tools that you have is going to help you make a better decision. So this patient actually did have glaucoma and not just megalopapillae. This is the trend analysis, not on this patient, just in general, what we talked about before, using not only your peripapillary thickness, but also looking at your GCC and your retinal thickness and looking at your trend lines underneath. So Adam, I think that we are just at 8:45, which is where I think we end. So hopefully everybody got a lot out of this, and I'm happy to answer any questions that anyone may have.
Great. Well, thank you, Julie. That was really great. I'm glad we were able to actually do this and get a little more in depth with the device. I think as a series, this has been really great. Helping people to get to know the Solix. So thank you so much for doing this. So again, if anyone has any questions, feel free to put them in the question box. And what we'll do is we'll do a little bit of verbal Q&A, and we will go from there. So let's see, clinical questions, practice management questions. Where do we want to go here first? Okay, I'll go for a clinical question. Question is, when you use this for a screening exam, do you, I'm sorry, I'm trying to read this. Okay, I'll simplify this. So dilation, when you're using the scan, do you dilate patients first before you do it?
You don't have to. That's one of the beautiful things about this technology, is that you can get a great scan through a non-dilated pupil. So usually no. In fact, I mean, the way that most of my colleagues are using it is they're getting it as part of kind of their screening tests, but you certainly can do it any way that you want. You can also do it while the patient's dilating and look at it before you even do your fundus exam.
Right. And question here, I guess this is a more general question about screening OCTs. So for folks who never have actually done this before, and I suppose this is a practice management question, how does it work in terms of the workflow of your clinic? So do all patients get a scan? Is it a certain subset? How do you decide?
So I'll answer that in two different ways. Remember that I'm in an academic setting, so we are anomalous, right? We're not the regular world out there. We try to do this, if we can, on as many patients as we can do it on. I mean, but in my colleagues that are using this, they will usually offer it as part of a package. So they'll say, get a fundus photo, although now this one has fundus photos on it, but get a fundus photo, get the OCT for X price. And they'll do it again, either while the patient's dilating or before dilation. So they offer it to them. Now, that doesn't mean everyone's going to do it, but if they do, want to do it, it's a one price deal, and they get the test done, and that's how, and they incorporate it however they want into the practice flow. Right. But they're offering it to everybody, Adam. I think that was the question, is, who should have it done? Certainly a diabetic, but how do we know, again, that patients have pathology, right? So if we're not doing it on everybody, and we're only saying, well, we're going to do it on a diabetic patient, we're going to do it on an AMD patient, we're going to miss half the disease that's out there.
Right. Interesting question here, practice management. I'm not sure you'll be able to answer this one, but does the anterior seg image for anterior seg depth qualify for gonioscopy reimbursement?
Don't know the answer to that.
Yep, and I wonder if any of the folks from Visionix who are around might know. If so, chime in, guys. But if not, what we'll do is we'll take the question offline, and where this archive will live with this archive video, we'll have a little discussion thread beneath it. And if I find the answer to that, I'll definitely post the answer there as well, and point people back to it. Oh, interesting question. So is the Angiowellness exam done separately than iWellness, and do you offer both?
So the Angiowellness is more of, it's part of the well. So you still do wellness, but then you also have to click on your angio scan. So basically you're doing your wellness scan and you're doing your angio scan. So it does take a little bit longer, but the beauty of it is that it will incorporate those wellness scans those angio scans into the wellness report. I would tell you that I don't do AngioWellness as much as I do wellness, just because it does take, because angio itself takes a little bit more time. So I usually start with the wellness scan. If there's something on there that seems off to me, then I will bring I'll bring the patient back just really for angio, not again for wellness. So AngioWellness is good if you have time to do it, but most people are doing angio separately. In other words, they're bringing them back for more advanced testing, and then doing all the angio scans.
Right. And I guess that brings up another question. How long does an angio scan actually take with the device, and do patients tolerate it pretty well, just holding in place?
So it takes about on a good patient, it takes seconds. It's really, really fast and easy. One thing that Solix does differently than Avanti is for those of you that have the Avanti, it would take two separate scans. You would get your horizontal cut. You can tell the patient, okay, take a second. Then we do the vertical cut, and that takes longer because patients tend to move and then it doesn't get lined up. With the Solix, it's one scan. There is a halfway point where we usually tell the patient, take a good blink. So it's faster because you're doing it all in one kind of acquisition. On a difficult patient, yeah, it might take some time if you need an artificial tear. Same as what we did with Avanti. It's a little bit longer. It depends on the patient.
Right. A question here, so that's interesting. So question, when you've done a wellness scan, you think you might see something, do you then do follow-up scans with wellness again, or do you do specific scans for the disease that you're interested in?
Correct. We don't repeat the wellness. So in a patient that has, an epiretinal membrane, or perhaps we're suspecting if there's a CNV, I'm going to do more scans that day. I'm not going to bring them back. But if it's a particular patient that has something else that maybe we want to bring them back on a different day, we're not going to repeat the wellness. We're going to actually now go into the beef of the machine and use those advanced imaging that they have, whether it's the angio or raster scans or some of the high definition scans that are going to give us much more information.
Right. And I guess in terms of repeating the wellness scan, how frequently would you do it? Would you have a patient back, like let's say there's no pathology, when would you repeat it? A year, 2 years, 5 years?
At their annual exam.
Okay, So
Yeah.
it really becomes part of their annual routine.
Exactly. It's almost like when you offer a patient an Optos or a wide field image, it's the same thing. We're doing this to screen for any disease. Most patients, you'd be surprised, are actually very interested in doing it, even more so because you don't have to dilate them. So if
Right,
you find something, then you say, well, now I really do have to dilate you. So patients are pretty good about doing it.
right. And I guess the follow-up question here is, so the best images to follow AMD or glaucoma are repeat angio exams?
Yeah, I mean, glaucoma is still kind of, I would say that angio is still new for glaucoma. Not new, but we're still learning a lot about it. For retinal disease, oh my God, I love angio. I mean, I do angio on almost all of my diabetic patients and almost all of my AMD patients, because you'd be surprised how much stuff is hidden behind the scenes. Glaucoma, I'm going to tell you the God's honest. I mean, I don't do angio on every glaucoma patient, but the report is so full, as I showed you without the angio, that it's great if you have a patient that's cooperative. If you can't do it, the report is so full of amazing information without it that it's not 100% necessary.
Right. And question here is, how are you using the FAZ information?
It used to be, if you were to ask me that question 2 years ago, I would have said, oh, well, if the FAZ is this size or bigger, it looks like they have advanced, diabetes. We don't do that anymore. Now we use the FAZ over time to determine change. So, if a patient has a 0.10 FAZ, and then you bring them back the next year and it's now 0.17, that shows that this patient's FAZ is enlarging and there's obviously some type of vascular non-perfusion going on. I don't think anybody anymore will say, if the FAZ is this size, then it's this category, because there's too much variability in it. So I would use it as I get a baseline, and then each time I see my diabetic patient, obviously I'm going to get the FAZ, and it should stay fairly stable. I mean, if a patient is getting worse, that number is going to change. So I think it really just depends on, the patient, their blood sugar control. If the patient has changes in their perimeter, though, so that area around the FAZ, meaning you see a lot of black spaces in the perimeter, that's actually an indication that, we know that if there's areas of black, there's not a lot of perfusion there, and that's a very powerful tool. So I tend to look more for the darkness than actually looking at a quantitative number, at least if you're only assessing them for the first time and you don't have metrics to compare it to.
Right. Oh, follow-up question here. They want to test your, if you're keeping up with the literature, can you speak about the latest on FAZ and Alzheimer's disease?
Oh Lord, well, I'll tell you that I know with Alzheimer's disease, this affects our vessel density. It affects not only the vessel density, but certainly it's going to make the FAZ large. I mean, not certainly, but I would think that it would make the FAZ larger because of the lack of perfusion. So I can't cite an article, but I will tell you that I know that the vessel density and the FAZ are both affected because there's not as much perfusion as an eye that doesn't have Alzheimer's.
Right. Interesting practice management question here. So let's say you have a known diabetic patient. They don't have retinopathy. Can you do angio and bill for it?
Yeah, this question comes up all the time. I do it. I would say that if it comes out normal, it's really meaning you don't see any areas where there's, capillary non-perfusion, where it looks pretty well perfused. It's difficult to bill it. If you can find an area where there may be capillary non-perfusion, you certainly can code it, in my opinion, as mild NPDR, moderate, whatever you're seeing, not based on what you're seeing clinically, but based on what you're seeing functionally. So I would code it, but I would also write underneath based on vessel density metrics or based on capillary, perfusion metrics or whatever you're using, because there's nothing clinically. So I think that that's a personal opinion. I don't think anyone would nail you on, coding something that you're seeing. If you're seeing it, then you can code it. You just have to be clear that you specifically say in there that it's not visible funduscopically.
Right. And I guess the next question is, so clinically, if nothing's really going on with this diabetic patient yet, but you're seeing those changes, what is it that you do with your patient in the chair at that
Yeah,
moment? What do you tell them?
So it's all about education, right? Because if you only look at a patient's fundus and there's no retinal, nothing there, you're going to say, you know what, you're doing fantastic. Go home and eat your ice cream. Go home and have your chocolate chip cookies. But if you notice something on OCT-A, but you don't see anything clinically, you're going to tell them something different. You're going to say, guess what? I see stuff here that in a year or two is going to manifest clinically if you don't change your behavior. So that's followed by a note to the internist or a note to the primary that we see these preemptive or preclinical changes that are going to eventually equate to the retinopathy if the patient doesn't modify their, what they're doing.
Right. And I guess that's an important follow-up. You always want to make sure that this gets back to the primary, since they're probably going to be in closer touch with them than you.
First and foremost, Adam, that's an excellent point.
Yep. Okay, great. And you used the term functionally before, so someone has a question. So functionally is a term, is that used to describe the vessel density?
Yeah, you know what, that's a bad word because what that means is you're looking really at how well the perfusion is. I mean, I can never think of a better word, but you're looking at how capable are the blood vessels at doing their job, So I'm looking really at, I should say, the functional integrity of the retina. I don't know if someone has a better word, but we always say structure is the OCT, function or how well the retina or the blood vessels are perfusing, meaning their function. So that's essentially what I'm referring to.
Got it. Okay, and it looks like we're coming up on it 1 hour, so I think we're going to have to end it here. So if there are any more questions, we'll definitely address them in the discussion thread that's going to follow the archive of this webinar. So Julie, thanks again for doing this, and thanks for doing the entire series. I think everyone's learned an awful lot about this instrument, even if so many of us still aren't traveling to trade shows, not getting out as much as we used to. This has been a really great experience being able to see all this stuff. So thank you so much for doing it.
Happy to help. And if anyone has any questions for me that they didn't think of, feel free to email me or someone at Visionix and they'll get in touch with me. Thanks for the opportunity, Adam.
All right. Well, thank you so much. And I guess thanks everyone for showing up, and I will see everyone online. So have a good night, everyone.